Hello, everyone, and welcome to the first in a series of webinars hosted by the Health and Internal Displacement Network. Today's webinar is titled Diverse Populations and the Health Impacts of Internal Displacement. My name is Diana Reyes, and I'm a PhD candidate at the Johns Hopkins Bloomberg School of Public Health, specializing in the impacts of conflict and displacement on the mental health of displaced populations. I'm also a non-resident fellow with the Tahrir Institute for Middle East Policy based in Washington, D.C. The Health and Internal Displacement Network, acronym HIDN, was launched in April 2021 to promote research engagement and evidence-driven policy on internally displaced persons, or IDP health. Today's event is the first in our new 2021 webinar series, and it builds on earlier expert workshops with researchers and policy actors that identified IDPs as the most affected population during conflict by disease and death, and also the most under-researched population. So while we know that conflict-driven internal displacement has an acute impact on the health of those who are forced to flee as IDPs, stratifications of gender, age, social diversity within a single IDP population is often hidden or underdiscovered. And this means that the disease burden varies greatly across this population. So what we'd like to review today in our webinar is how can health policy and interventions respond to the differential health impact of internal displacement on IDP populations. You will hear from three of our leading researchers within our network to discuss how such outcomes are distributed within and between different IDP populations and profile. And our speakers will start us off by presenting their key research on the different components of this issue. After that, we'll open up for broader discussion, and we welcome questions and comments from other participants. And during the session, please feel free to post your comments in the chat box on Zoom. So after the speakers have finished their presentations, there will be time for them to discuss and reflect on your questions and comments. Some housekeeping rules is to keep your microphones on mute and your videos off unless you're a presenter. The session is being recorded and will be posted online as a podcast, so please feel free to share this later with your networks. If you do not wish to appear in the podcast, then it's advisable to leave the session now, and please advise that the session will be recorded. So without further ado, we will turn to our first speaker, Professor Zulfikar Bhutta, founder of both the Center of Excellence in Women and Child Health and the Institute of Global Health and Development at Aga Khan University in Pakistan. And he'll be speaking about IDP, child and maternal health in Pakistan and the Middle East region. Over to you, Zulfi.
Thank you very much, Diana. And let me share my screen if I can. So somebody has to enable the participant sharing.
Sure, you should be a co-host now.
Yeah, thank you. Okay, so you let me know kindly when you can see the slides.
Yeah, looks great.
I'll change the display settings so you can see the full thing. Okay. So wonderful to be able to share some thoughts with you. I'll try and cover a fairly large area or body of work in about 10 or 12 minutes. So let me start by looking at Afghanistan. And to many people in this audience, you have probably heard about the conflict in Afghanistan for well over the last 3 decades. And it's not too surprising when you look at what's happened. There's some major timelines that began with the Soviet invasion of Afghanistan in the wake of the instability following the overthrow of the king. And then after that, a major Taliban movement once the chaos post-Soviet departure overtook the entire country. And over the last decade or so, we have seen a significant exacerbation of conflict. And today, as we speak about the coalition troops, mainly the US troops leaving Afghanistan, there's a lot of uncertainty around what has happened. As you can see from this graphic, if you look at the areas affected by conflict, they're all the regions of Afghanistan, but it's specifically concentrated in the southwest and some regions that abut the northeastern part of its border with Pakistan. And this intensity of conflict is largely based on battle-related deaths. It is also not too surprising when you look at internal displacements. Although there are a number of Afghanistan refugees in bordering countries, Afghanistan, Iran and Pakistan, it is largely internal to the neighboring provinces to where conflict is concentrated. And that's been a universal observation in many places, that the most important areas of displacement are generally the contiguous, relatively stable areas. So the context is important. It is hugely important to recognize that Afghanistan faces a double burden, not only displacement because of internal insecurity and conflict, but also a combination with natural hazards, a huge impact of climate change in terms of agriculture productivity of land, and people's movements, because following disasters, there is virtually no rehabilitation and rebuilding. So the internal displacement is complicated by economic migration because of unemployment, poverty, and also lack of basic services and development. This has become a survival strategy for many Afghans, and that's why when you look at the numbers, both in terms of stock or stable displacement numbers and those that are exacerbated when conflict peaks or exacerbates, you will see that over the last few years, these numbers have borne quite close relationship. And today, upwards of 70 or 80% of all the Afghan displaced internal population is within the country or in the immediate neighboring countries. Pakistan has been relatively stable. There hasn't been long-standing conflict in the country, but there have been major military coups and certainly sectarian violence in the region, given the diversity of its population. If you look at also the country has been exposed to humanitarian emergencies over this period, earthquake, floods, but by and large, most of the recent displacement in the countries, particularly in the two provinces affected of Balochistan and Khyber Pakhtunkhwa, the previously called Northwest Frontier Province, have been as a consequence of terrorism and insecurity. And it has had a huge economic burden on the country, estimated to have cost over $100 billion over this time frame. And you can see this very clearly here, that most of the internal displacements, conflict events, have been within the last decade or so. They are also concentrated largely in the regions that you see highlighted where there have also been event concentrations, these areas of the Northwest and also parts of Balochistan, which is very sparsely populated. But you will note over here that almost all areas of Balochistan have been affected in terms of insecurity and displacement of people to neighboring provinces of Sindh and Punjab. So the context again in Pakistan has been largely conflict related and also related to law enforcement and military movements against pockets of populations, including even large-scale displacement. It happened with the area of Swat a few years ago when the local insurgents took over and were displaced by a military movement that almost displaced the entire population of Swat out of that region for several months. So here we see that because there isn't a backstream of migration because of economic reasons, that there is quite a close relationship of the numbers of displaced people and actual events related to conflict in the country. The Middle East is a complex situation, and I don't have enough time to go through all of this, but I will illustrate this with a few examples. So if you look at the number of people displaced in Middle East and North Africa, the MENA region, there are close to around 3 million people displaced, about 10% of the global total, and 2.5 of these are related to conflict. But there are also some which are related to disasters, and the most obvious are things like natural disasters due to earthquake and like. The so-called people of concern, people who are affected by all of this, if you look at the vast majority, although the focus in the media and attention may be around refugees and asylum seekers, but you will note that in the overall numbers, it is actually the IDPs that far, far outweigh any of the others. And some of them are stateless. Some of them also convert into refugees when they move into other countries, but a large number remain within the countries themselves, displaced from their root sources. You can see this in the context of people just migrating and moving to neighboring areas. This is the map of Afghanistan, which tells you what is the location of displacement events following conflict and violence in one particular year. Here is 2019. And you can see that from the areas affected by conflict itself, most displaced to the neighboring region, to the Kurdistan region here in Iraq. In Yemen, for example, You see this very clearly with these arrows showing the movements of internal displaced people, largely in relation to the aerial bombardment and insecurity because of the conflict exacerbation, which people just could not stay in a particular area because of insecurity of life and limb. So most of the movement was in the neighborhood of people moving away from where the aerial airstrikes took place. Syria is a bit more complicated, and that's an understatement perhaps, but you also see that in Syria, displacement is a lot more complex, and because of the various warring factions, both the anti-government and pro-government forces, this is a lot more dispersed, but mainly concentrates around the area bordering Turkey, where some secure zones have been created. But what is the impact that this has on children and on families? And I'm going to speak largely about women and children in the context of internal displacement. We recently summarized some of these effects in internally displaced populations and refugees in the context of toxic stress. And if you look at this across a life course, whether it is from a pregnancy situation to what happens during childhood and adolescence, there are a huge number of pathways through which toxic stress affects the lives and livelihoods of these families and children. They can be health conditions, but there's certainly poverty plays a massive role in terms of people's ability to cope. Mental trauma, certainly exposure to violence, and also things that we have not been able to quantify very well, such as displacement and social isolation, just people losing their roots. There has been a lot of focus on sexual and reproductive health and sexual violence in particular around the Middle Eastern sectors like Syria. So there is more information on certain tangible things, much more so than the intangibles that are related to long-term effect on mental health development, which can have not only effect across a generation, but between intergenerational effects. And those are things that we have begun to talk about. In terms of impact and its diversity, these are some equiplots. Equiplots are plots that look at equity indicators in relation to coverage of various health interventions. These are data for Afghanistan. The severe conflict is represented in these red dots. And here you have coverage of various interventions ranging from 0 to 50%. And you will notice that both for severe and moderate conflict, there is a huge impact on reproductive maternal and child health coverage. And for things like family planning, these are much, much lower than where the gradient of conflict is much less. Same is the situation in Pakistan over the last decade. When we have looked at this, that you find that the very worst, and you see that interestingly here, the dispersion is different from that of Afghanistan. Here you saw the moderate and severe clustering a bit close together. Here you see the most of the impact is really on those that are severely affected by the severity of conflict itself. So it matters, and this matters also in terms of where these people are located in terms of targeting. Going beyond health, schooling disruption is a major consequence of displacement. You see here data for male children and female children in school in Afghanistan, and a comparison of government and controlled and non-controlled areas. First thing to take home is not much different. Even in government-controlled areas, a vast majority of girls are out of school. So you see the gender differential with about 60% of girls being out of school in both areas, and the proportion for boys is about 40%. So schooling loss, pretty major. Other is an impact of poverty. Many of these children are forced to work. And here, if you look at what kind of work that they are involved in, is generally menial labor, informal. This is children working and earning various amounts. And if you were to convert, those who are earning less than 1,500 Afghanis a day, which is what you'll see, so less than $1.50 a day, that is also pretty much concentrated in IDPs, much higher in IDPs than in terms of returnees or other refugees. I talked a little bit about the intergenerational effect of conflict, and this growing body is emerging from various conflicts that have been studied, notably from Africa, and there is data available from the consequence of the Rwandan genocide. but it's also beginning to emerge from these very regions, from Afghanistan, Pakistan sector, and the Middle East. To give you an example of this one study, which looked at low birth weight in displaced populations as a consequence of maternal undernutrition, stress, mental health issues, and low birth weight in particular has an impact in terms of a life course that goes well beyond a single life experience of an individual. So it can have intergenerational effects and can have certainly epigenetic consequences. So I want to finish by some recent work that we have done just to illustrate that it's not all just diagnosis, that people are moving from diagnosis to prognosis and in fact interventions. And a lot of work of our recent Lancet branch consortium compendia of papers was focused on what could be done about women and children in various settings. And they included refugee children as well as IDPs. And I just want to go through those key messages. Firstly, while we know a lot, and I've shared some of what we know with you, there are massive data gaps, whereas there's virtually no information. And because nobody collects it, it's just not a priority for organizations. So they include things like information on conflict-related adverse pregnancy outcomes like stillbirths, miscarriages, or exposures in orphanhood, school-age children, adolescents, and the intergenerational effects that I've just talked about. We just don't have enough on that as we speak. We do have interventions that work, but they have not been universally or uniformly applied in various conflict settings, and especially those that reach those who are marginalized. The whole point in doing an equity analysis to find those who just fall through the cracks and are the poorest amongst the poor or the most neglected is that you can make some difference to them, that you can reach them much better. And these include interventions like community outreach services to health workers, mental health interventions, and interventions to address special needs of school children and adolescents. These are just not within the remit or within the work packages of many relief agencies as we speak, not to the extent that we need, and that needs to be expedited. How do we implement this is a big question because it varies very differently in various contexts. Context of severity, context of geography, socio-cultural context. So there's the need for much greater implementation research to assess optimal ways of reaching those who are in greatest need, women, children, adolescents among displaced populations, and their integration within existing health systems. And importantly, and finally, what packages to implement which are both cost-effective and sustainable. Sustainability is a big issue. There are so many people who have come and done pilot projects only to disappear once the funding ran out. And I personally feel it's very important that only such implementation research take place that can actually help the population at need, and a discussion and negotiation be undertaken with both public sector policymakers as well as development agencies as to what will stay in place once the researchers are gone. Well, thank you very much for your attention. This is perhaps a reasonable summary, and I'll be happy to answer questions in the discussion.
Thank you very much, Zulfi, for your quick yet comprehensive overview of the IDP situation in Afghanistan, Pakistan, and the Middle Eastern region. That's no easy feat in less than 12 minutes. I particularly appreciated your emphasis on the health of IDP children and women. I've noticed that in health and conflict research, we often group IDP populations together by age or gender, but you also highlighted the importance of considering context of severity, of conflict severity, of geography, of sociocultural needs when trying to reach these populations. So thank you so much for that overview. For those of you who have just joined us, welcome. And if you have questions for Professor Bhutta, please post these in the chat box and he'll answer them during the Q&A session. We'll move forward now with our next speaker, Professor Bukola Salami, Associate Professor at the Faculty of Nursing, University of Alberta, Canada. She'll be speaking about the health of internally displaced children in Africa. Over to you, Bukola.
Thank you very much. Would you be able to make me an host so I can share my slide?
Of course. You should be able to share it now.
Okay, I can share it now. So I hope everyone can see my slides. I will be speaking today about the health of internally displaced children in Africa. And my talk today will be focused on some of the work that I have done with a scoping review of the literature on health of internally displaced children. So there are 244 million international migrants, a large number of people, about 740 million, are internal migrants in the world. So we have more internal migrants than international migrants. There were 31 million international migrant children in 2015. 3 out of 5 migrant children are from Africa, Asia, and their diverse population. While there's emerging literature describing the challenges of African migrant children and youth in the global north, there's paucity of information regarding the well-being of displaced children and youths in the global south, where displacement tends to exacerbate existing health and social conditions. In the global north, there's also limited intervention studies and comparative analysis. Also, limited data have been collected from children themselves, and it is crucial. So we developed a network to address some of the paucity of these data gaps. So I founded the African Child and Youth Migration Network in 2018, and we seek to develop and mobilize knowledge to improve policies and practices that will contribute to the well-being of African migrant children. So far we've conducted a series of scoping reviews of the literature on African migrant children. We have 3 papers that have been published, 4 papers that are in the publication process. And one of those papers is on internally displaced children, which I will be presenting today. We also have a paper on the overall data on African migrant children that it doesn't really include internally displaced. And we have about 188 studies across the globe that have been done on African migrant children. And we also have a paper that has been published on reproductive and sexual health. We have other papers coming up, one on mental health, one on refugee children, African immigrant children, African refugee children, nutrition, and mental health. We've also delivered a graduate student webinar in 2019 on methodological issues of researching migrants. And we are currently in the process, we have funding through Social Sciences and Humanities Research Council of Canada to collect data across the globe on African migrant children. So we recently finished data collection on the health of and the well-being, broader well-being of internally displaced children and parents from Ethiopia. We just finished the data collection for that, but I won't be specifically presenting the data for that today. We are also in the early stages of starting data collection on our project on in Nigeria, and we just finished doing some interviews also in Canada, not on IDPs, but more of migrant children. So here is our first scoping review on the health of internally displaced African migrant children, and that was published in International Journal of Environmental and Public Health Research. And for this, we analyzed data from around 188 studies. The next one that we published is the health of internally displaced children in Sub-Saharan Africa, and I'll be presenting some of this, and it's published in BMJ Global Health. And then there's another that we published, a review of the literature on sexual and reproductive health of African migrant refugee children. And that's published, I believe, in BMC, BMC Reproductive Health. So in regards to health of internally displaced children, when we did our scoping review, we did all the reviews together. So we had a broad search strategy. So we started with around 6,000 articles. And from that, after choosing those that I focused on IDP from that. We had 25 articles that met our inclusion criteria, 16 quantitative and 6 were qualitative and 3 were mixed methods. And this is consistent with a lot of the data in the other reviews that we did, that we have in Africa. We have more quantitative studies published than qualitative studies and mixed method studies, and even less intervention studies. So some of the results shows infectious diseases, so elevated health problem and infection in this population, poor sanitary conditions, including unclean water, deplorable conditions, insecurity, were main factors that predisposed displaced children to infectious diseases. And some studies are showing that boys are more prone to infectious diseases than girls. Altogether, there were 6 articles in this area. We also found growth and child nutrition issues. Finding on the nutritional problem, issues of internally displaced children are quite broad and are mixed, with some showing poor nutritional status among children in this group and others showing poorer nutritional status in host societies. And what this points to is the need to also consider not just the health of internally displaced children and youth, but also what are the gaps or the challenges in health status of all society, of course, oftentimes due to resource constraints due to the migration of internally displaced children into those societies. We also found high rates of internalizing problems and post-traumatic mental health challenges. Mental health is often described in locally specific ways that merge Western understanding with cultural understanding. And there's a need for school-based programs that can improve mental health. And 8 articles focused on child mental health and psychological well-being. In the research that we've done in Ethiopia, and we are still in the process of analyzing the data, one of the things that we found is issues of trauma is, it's not just something that happens pre-migration. There's pre-migration trauma. There's trauma that happens during the migration process, including sexual exploitation. And then there's also trauma that happens while IDPs are displaced in their setting, in their IDP setting too. We also found issues with health system delivery. Institutional and broader social cultural factors contribute to poorer health of newborn and small for gestational babies in displaced community. These factors can include lack of professional birth attendance and postnatal care services, as well as harmful traditional newborn care practices, such as mixed feeding, use of herbal infusion. And then access to services, including reproductive services, is often a challenge for this population. And I know in some data that we've collected we collected data in the past on internally displaced women in Nigeria, and we did find challenges in terms of reproductive and sexual health of women, including especially access to reproductive and sexual health services, which is often basically non-existent. I will just touch a bit about, our mixed method study that we looked at. Our review that we looked at on African migrant children. This was a huge task to review 188 studies that from our scoping review that were African migrant children across the globe. A majority of them, just similar to the ones that we did on IDPs, were quantitative. Were limited, were qualitative and mixed methods. And issues that we observed were issues related to nutrition, which was the most frequently discussed papers were focused on nutrition, infectious diseases, mental health, birth outcomes and sexual and reproductive health, physical and developmental problems, including issues related to fine motor skills, social emotional domain, poor growth, autism. If you notice in the work related to IDP, we tend not to actually find much research on IDPs and issues related to autism and fine motor skills and social emotional development. A parasitic infection, consistent with some of the data that we found in IDP, Oral health, including oral caries, has been discussed generally on African migrant children, but that research does not really exist as much in IDP children. Respiratory health problems, preventive health services such as vaccine uptake, again, not as much featured in the IDP literature, and also endocrine problems, including type 1 diabetes, goiter, again, not featured in IDP literature, and health services and hematological conditions. So between the literature on health of African migrant children in general, and health of internally displaced children specifically, there are actually differences in terms of the focus of a lot of the research. The focus of a lot of the research on IDP specifically has been on infectious diseases, mental health service, and access to health services, while the ones on African migrant children in general tends to be much broader, to focus also on chronic diseases that African migrant children may face in destination countries. So some of the research gaps include geographical misdistribution. For example, a lot of the IDP research that we found were largely focused in East Africa. And we found limited studies on IDP children, especially Uganda. There was a lot in Uganda and Ethiopia. But there's limited research on IDP children in West Africa, especially with the increasing, well, it's not increasing now, but where the Boko Haram insurgents and some of the insurgencies in other parts of Africa. A lot of the data has been largely quantitative. Often it's been descriptive in nature, especially the qualitative data has been descriptive in nature with no theoretical framework or in-depth insight guiding it. Stronger methodologies needed, including sampling. So sampling, is including in quantitative data, tends to be convenient sample approach. Oftentimes data has been collected not from children themselves, but from parents. There's limited data from, just in terms of our research, our findings related to African migrant children in general. There is limited research on children aged 1 to 11 years old. So there tends to be research on those less than 1 and also research on those 12 to 18 years old, but less on between the age of 1 and 11. Quantitative instruments that are often used in a lot of the data collection tends to be Western instruments with limited local testing, and mental health studies focus primarily on refugee children. And there's a need in looking at undocumented and trafficked children and unaccompanied minors. And I believe there's also a need in terms of looking at intervention studies. So yes, we do have data consistently that shows mental health issues in internally displaced children and refugee children, but we need to move from just data to actually seeing about in what ways can we improve health status for these populations. And I think that's my presentation, and I think maybe I was on time.
Yes, thank you very much, Bukola, for this insightful presentation. You were perfectly on time. And congratulations on your multiple academic publications and continued contributions to this area of work. I think your research clearly demonstrates the gaps, challenges, and key areas remaining for implementation to address IDP child health. And it also demonstrates the value of focusing on a particular IDP population in terms of age group and then also region in Sub-Saharan Africa in order to start identifying and developing solutions. So thank you very much. We'll move on to our final speaker, last but not least, Dr. Ala Abbara, who's a consultant in infectious diseases at Imperial College and an honorary clinical senior lecturer at Imperial College and co-chair of the Syria Public Health Network. She'll be speaking about the health of IDPs in Syria. Over to you, Ala. You should be able to share your screen.
That's super. Thank you very much, Diana. And thank you very much to the organisers for asking me to speak today. There we go. So what I was going to do is speak about the health of IDPs in Syria. And what I was going to do is start with a description of the scale of forced internal displacement in Syria, discuss some of the key health impacts, and actually it's been really lovely to listen to the previous two speakers, because there's important parallels, but of course important differences when we discuss Syria. And then I'm going to start the discussion about the way forward in terms of academic priorities and policies. And I thought this map was very useful just to give an idea of the extent of displacement up until the end of 2019. And of course, for Syria, that's very pertinent because through 2020, we saw a tremendous amount of new forced displacement within those few months before the COVID-19 pandemic took a hold. What's important to note here is where the countries with the greatest burden of IDPs exist. And you can see at the bottom here that 45.7 million people internationally are internally displaced. And whenever I speak, I always try to remind people why discussions about Syria are important. You may be forgiven for thinking that the conflict, having been going on for more than 10 years now, may be dying down, but in fact, the humanitarian crisis and in fact the conflict remains almost as acute as ever. The other important note to note from this slide is of the 10 countries with the highest number of IDPs as of 2019, they account for the majority of IDPs internationally. And of course, it's worth remembering that here we're talking about conflict and violence as the cause of the forced displacement, rather than natural disasters. And in fact, that map would look rather different. So in Syria, there's been almost 6.5 million people in 2019 who are internally displaced. And if you recall, more than half of Syria's population of 22 million have been displaced, including more than 5 million refugees from Syria. What I wanted to do here was just to refocus as to how we got to this point. So this is a map from March 2013, and you can see in green the areas that were under government control, these areas in pink which were under rebel control at that time. And it was in March 2011 when there were peaceful uprisings where people took to the streets asking for freedom, reduction in corruption. And of course, this was violently suppressed. And by the summer of 2012, there were increasing artillery attacks. And so this is from my hometown of Homs, and you can see that these are civilians that were attacked by artilleries, missiles, barrel bombs. And it was directly against civilian infrastructures, hospitals, schools, markets, and then onwards. And this is particularly poignant because from 2012 onwards is really when internal displacement, forced internal displacement, increases in the conflict became even more significant. And what we know now in terms of the indices of Syria is that more than 500,000 have been killed in Syria. And of course, many are in need of humanitarian assistance and many have been forced from their homes. And the other important thing to note, and I don't think we can discuss the situation with regards to IDPs without discussing the health system. So we can no longer now talk about Syria's health system as a whole. It's fragmented, it's politicized, and broadly speaking, it covers 4 main areas, but of course there are micro contexts within these areas. And of course, within them, they are affected by numbers of IDPs, returnees, detainees, and of course, different health burdens across different parts of the country. So this area in yellow is areas currently under government control. So this map is from July 2020, and this currently accounts for around 2/3 of the country. And up here in the northeast, you'll be familiar with the areas of Deir ez-Zor, Hasaka, and these are under SDF control, so Syrian Defence Forces control. And importantly to note, even before the conflict, this area was under-resourced, and there was a lack of investment in healthcare. And this is something that we're seeing now in terms of even worse outcomes for both local populations, but also for the IDP communities in this area. So in terms of the numbers that we're talking about in the Northeast, it's about 3.2 million people in this area, with a few 100,000 who are internally displaced people. What's interesting about the Northeast is many of the IDPs are in fact residing with local communities. So there's the estimates vary, about 100,000 who are living in the tented settlements. So you'll be familiar with Al Hol refugee camp, for example, where sadly the majority are women and children, and it's not infrequent that we hear of deaths from diarrheal infections among neonates and inadequate resources, and of course they're suffering terribly in this area as a result of the COVID-19 pandemic at the moment. And then there's these areas in the northwest. So the area in blue and some of the checkered areas up here are under Turkish control. And then this area in red is what's named Northwest Syria. It's mostly Idlib governorate with a bit of Aleppo governorate. And in the last year and a half or so, it's seen some of the most tremendous amounts of violence as anywhere in the country. And it's important to note that when we discuss the attacks on healthcare, when we discuss the attacks on civilian, more than 90% are actioned by the Syrian government and its allies. And what sits in this area is about 4.2 million people. And you can see that you've got now closed because of the COVID-19 Turkish border on one side, and then government, the kind of cross-line areas here. So these are people who are essentially trapped in this area. I hope when we start the discussion, we can discuss some of the impacts of the UN Security Council resolutions on cross-border aid, because that's had significant impacts on the humanitarian situation and the COVID-19 response in northeast Syria, including for IDPs, and it will be more significant in the northwest. Why am I focusing on the northwest? Well, in this area, there's about 4.2 million people. More than 2/3 are people who've been internally displaced. And of these, probably around 1 million are in tented settlements. And the majority of IDPs in this area are women and children. So between about December 2019 and February 2020, there were almost 1 million displacements, forced displacements, of whom 80% were women and children. I put this here in case you wanted to read more about the fragmented health system in Syria, because it's important for us to understand pre-existing conditions in terms of the health system in Syria, but also what's now happened with changes in the geopolitical context. This figure is taken from the Internal Displacement Monitoring Centre, and what it shows quite clearly is the new displacements. These are the bars in orange, and you can see that they seem to sit around between 1 and 2 million, except here in 2017 when the new forced displacements hit 3 million. And in terms of the internal displacements across this time, is sitting usually at about 6.5 million. It's dropped very recently to about 6.2 million. And of course, this continues, and it continues into 2020. When we look at these and we start thinking about numbers, I always think it's very important to remember that when we start talking about millions of people, it can be hard to understand that every single one of these people has a horrific lived experience of displacement. I've had family who were displaced from Homs and then they moved away. For example, on the 25th of May 2012, there was a horrific massacre. And so they left for about a month, horrific massacre out in the area they live in, Homs. And at that time, they were forced to leave, but after a few weeks, they thought it would be safe and they came back. And then when the Syrian government entered the area, they fled again. And when they thought it was safe, they would come back. So a lot of people may have been displaced once, but certainly a very large number have faced multiple displacements across the country. And of course, they have multiple vulnerabilities and are often marginalized. And they may face discrimination in normal day-to-day living, but of course in healthcare access. And that's an important thing for us to discuss today. So in terms of the equity of access, it may not be the same as for local populations. And the other important thing to note is actually the majority of IDPs are often women, children, and those with vulnerability. So for example, those who are disabled or have chronic conditions. Living conditions for the vast majority of IDPs is substandard. So the protection cluster and those in charge of shelter are trying to address this, but of course they're making very little headway. And that's particularly pertinent, particularly in the winter months, but as we face flooding and other natural disasters on top of the conflict and violence associated disasters. So in terms of health, of course, this leads to a number of things. There's a spread of communicable diseases, there's a risk of malnutrition, there's impacts on sexual and reproductive health, but also on sexual and gender-based violence. And of course, all of these interact very closely with things that relate to mental health. As Zulfi alluded to, there's an impact on education. Of course, education is really important in terms of mental health, protection issues, keeping children from entering forced labour or early forced marriages. And of course, water and sanitation is significantly affected, not just because it's been attacked and interfered with deliberately and directly as a direct consequence of the conflict, but also the quality of water for drinking, for washing, and then onwards is significantly affected. And this is nicely outlined in the New York Times article from March of 2020, when this area in the Northwest, when we were coming up with policies around how to prevent COVID-19, we really need to think about these local contexts where there may be a dozen people living in a tent. The idea of stay-at-home orders or of isolation or quarantine are very difficult. And in terms of a pandemic, in terms of communicable diseases, you can see how quickly it can run through camps such as these. And of course, healthcare access and sometimes mistrust of the local health providers can be quite significant. So I put this map up because I think it's rich in its complexity. It's taken from January to December 2020, and it shows me very much that the humanitarian situation, the conflict, the adverse effects on civilians remain significant. You can see the greatest activity is up here in the Northwest, and these areas in the very dark blue where there's the greatest number of IDPs. So you can see this area in the Northwest and this area in the Northeast and this area around Damascus lighting up. As I said, that in this area in the Northwest, almost 1 million people were forced from their home with some of the most relentless shelling, including on hospital facilities, on civilian infrastructure, on WASH infrastructure that has been seen throughout the conflict for a population that are almost trapped in this very small area. This is a piece that we wrote for Lancet Migration on looking at forcibly displaced populations inside Syria, but through the lens of COVID-19. I put it here because it might give more detail around the Northeast, the Northwest, and other areas where there is large numbers of internally displaced people in Syria. So what is it that people are fleeing from? It's fleeing from violence, indiscriminate attacks, deliberate attacks, forced detentions, forced conscriptions, and then inadequate healthcare. And there's been a very deliberate program of attacks on healthcare in Syria. And I don't think we can discuss different things around health indices without understanding that this is a health system in which more than 60% of health facilities are not functioning. And of course, there are some areas where that's more so than in other areas. There's also been direct attacks on medical personnel, and that's forced many of them who would otherwise have stayed, either for themselves and their families to be internally displaced or for them to be displaced outside of the country as refugees. This leaves a dearth of personnel able to support the health system both now and as we look into the future. And of course, there's a major problem with regards to medical education and healthcare education inside the country. I'm just looking at the time, so I'll speed up a little bit. But on this, I just wanted you to note that in terms of medical personnel killed, you can see that Aleppo, Idlib, and Damascus suburbs have been among the most affected. And there's been more than 930 healthcare workers killed across Syria. More than 90% of these have been by the Syrian government and its allies. I'm not going to talk in depth about these key health issues. And the main reason is actually there's a dearth of data around healthcare in Syria at all, let alone that which differentiates between the particular health needs of IDPs, marginalized and other marginalized populations. And in that, I would include detainees. We don't know how many people in Syria remain in prison. There's estimates of at least 140,000, but of course their health needs are very great. There's been it's been estimated that between over 1 million, and the reason I'm hesitating is I've seen estimates of 1 million or 3 million people with disabilities and injuries, and many of them are due to the conflict. And I expect that may be relating to, one, we don't know how to count these because the health system and the health systems isn't strong enough to do so, but also because there may be different definitions. If you do look at the literature about IDPs in Syria, the signals that mainly come out are non-communicable diseases and mental health. But actually, as Bucolo quite nicely highlighted, a lot of these are descriptive. They may be cross-sectional, retrospective. There are very few, perhaps kind of useful academic papers which explore interventions which are potentially useful and actionable in that setting. I'm going to skip these slides on cutaneous leishmaniasis, but the point to make there is actually with forced displacement, communicable diseases can go from areas of endemicity to areas where it has not been endemic previously. I wanted to highlight this paper written by some of my colleagues because it's one of the few papers that actually directly explore the needs of displaced people. And of course, this is through the COVID-19 lens. And I don't think any discussion around healthcare or health burdens is complete without a discussion or an understanding of social determinants. And in Syria, these are absolutely key because it affects everything from mental health to communicable diseases, non-communicable diseases, and onwards. And I do want to highlight some of these things which those of us who are clinicians might otherwise ignore, and this is all those things which relate to community and social context, and they relate to discrimination. Of course, there are political determinants, social determinants here, which have a direct impact on health. I'm going to speed up, and if there's a time to come back to this, I can do so and discuss those in more depth. So in terms of the way forward, I've left this as a question mark because I think it's one of those things that firstly, perhaps it's not for me to make decisions around the way forward around healthcare of IDPs. It needs to become from within the IDP communities for them to be able to advocate for themselves and contribute to the prioritization, but also to recommend and come up with interventions that may suit them in their local micro contexts. The inclusive here I'm referring to is we mustn't forget that, yes, of course, you could be an IDP, but actually local populations in a country where more than 80% of people live in poverty are significantly affected with similar health burdens. And in fact, relating to this, we use IDPs as a catch-all term, but I would say that's very dangerous. Everyone is an individual, but also there's different intersecting vulnerabilities which need to be taken into account. For example, you could be an IDP, but you could be a doctor who has access to being able to work, being able to support your family, which is very different than if you are from a rural area, or you may be a subsistence farmer or a teacher who's unable to find work. The key points here around baseline interventions is actually there's a dearth of data as to the situation for IDPs now, and that's both quantitative and qualitative, but also there's almost absent data in terms of what interventions can support IDPs in their health burdens, with perhaps some exceptions from the IRC around cash-based interventions, but I wouldn't say that necessarily directly influences health. And so I'm going to stop there, and I'm going to apologize to Diana for overrunning.
Thank you so much, Ala. That was a wonderful presentation, very straightforward despite such a complex humanitarian context. So we really appreciate you walking us through that. I also really appreciated you highlighting sort of the modern and relevant issues that are facing IDPs in Syria to this day, including the COVID-19 pandemic, ongoing hostilities across the different geographical regions, definitely the economic situation facing the IDP population there, and now the uncertainty surrounding the upcoming cross-border resolution in the Northwest. So I hope we can continue chatting about this in the Q&A. Thank you again to all of our speakers for these thought-provoking presentations. I will ask each of our speakers now to refer to questions and comments made in the Zoom chat box regarding their respective presentations. We'll go in the order that the presentations were given. So we'll start with Professor Bhutta to address questions and comments on your presentation. We'll give you about 5 minutes to do so.
Thank you, Dana. I mean, there are three substantive questions that I could spot in the chat. One I can take care of pretty quickly, which was around the situation in Tigray, and I hope Bukola will address that. I was largely focused on Middle East and the situation in Afghanistan and Pakistan, but we all recognize what a massive humanitarian disaster it is in terms of what's happening in Ethiopia and the internal displacement it has caused. So I hope my colleagues will address that. There were two related questions, and David has asked a very specific question on the intergenerational aspects that I will refer to in a second. But there is one that I want to take first, which is on what are the potential differences in psychosocial effects, if any, between Afghanistan, Syria, and Yemen. So the answer to that question is we don't quite know, because a lot depends upon the severity and duration of effect. Afghanistan is different because this has been going on for now close to, as you can imagine, 4 decades, starting from 1979 and potentially even before. I began my career as a pediatrician in a refugee camp back in 1978 in that region, where already refugees were beginning to trickle in from Afghanistan as part of that conflict. You can imagine how long this has been. And I wrote a paper that I keep very precious because it was written in a hurry and it was written from the heart, and it was written about 20 years ago. And it was called Children of War. And it was the story of what we felt in the absence of much data as to what was happening in that region. And it talked about what happens to a generation that is brought up in conflict. And it sees nothing but conflict in front of itself. So the long-term effects and psychosocial effects quite depend upon the severity as well as duration of exposure. Children who have grown up and seen nothing but suffering around them, have seen a pattern of violence, will often also become inured to it. And one of the prescient things that I wish I hadn't said, but I said in that paper, over two and a bit decades ago, was that these very children will grow up to become, potentially some of them, perpetrators of the violence themselves because they're so inured to it. And that's exactly what has happened. That in many of these places, people who grow up seeing nothing but violence start to consider that as a way of life. And I particularly worry about gender-based violence, and I worry about normalization of behavior when you see nothing like that around you. So there are differences, therefore, between short-term conflicts and long-term conflicts. But having said that, atrocities are atrocities anywhere and everywhere. And
Oh, Sophie, you've been muted. Do you mind?
No, I didn't mute. The host muted me. Maybe I said something wrong. So kindly don't mute me again. So give me a hand signal if I am undiplomatic. But so what I was saying was that in many places, in addition to the longevity, it also depends upon the nature of conflict. So in Syria in particular, as Dr. Ibarra mentioned, the kind of atrocities that we saw, particularly with the violence, extreme violence towards some minorities and the kind of subjugation of women was extreme. It was never seen, even though the Taliban are or have been no friends of gender equity. But the kind of violence that you saw in some of these Middle Eastern conflicts under the guise of so-called jihadists was unheard of in modern conflict. And that never happened. And that has huge impacts on psychosocial health. So there are those differences that we see. There's a code of honor between, in various regions, particularly in the Pashtun population. And that has been respected by and large in the conflict in the AFPAC region. Finally, in terms of this particular aspect, a lot also depends upon the politicization of these conflicts. So what happens in a situation like the AFPAC region is that the original question or the original problem is often lost. And it's lost between the power games that many of the superpowers engage in terms of exerting influence. So the Afghan conflict is no longer around the original deprivations and the original root causes of the conflict in the 70s. when people rebelled because they had an authoritarian regime and they were witnessing inequities in front of them. Now what you have is a mishmash of interests of the West, the local countries, the whole issue of the US versus China, and that is the Pakistan-India conflict. This is clouding everything in that area, and that again, is deplorable, but has a huge impact in terms of how quickly can you get to rehabilitation. Let me now quickly turn to David's question, which is on intergenerational aspects. And we believe these are neglected. We believe these are real. And we believe these are substantial in terms of their long-term impact. And if you convert all of those into a dollar figure, it may be that this is probably the most expensive cost of war. Now, what do I mean by that? So we all know that some of these developmental trajectories of children in particular are so affected by these early exposures. And they're affected by exposures that you and I recognize from things that I just told you about: exposure to violence, exposure to physical torment, torture, healthcare deprivation, etc. But the subtle effects that you have on psychosocial development trajectories can have long-term consequences that go beyond the generation itself. So we now know, for example, that in the periconceptual period and before, some of these adverse exposures can have epigenetic influences, and they can impact, therefore, what may happen to your next generation, and can only be reversed over time. It's not that they are irreversible, but they are definitely there, and they potentially are much more consequential than something that you can see and rectify. But you can't see this, and you can't see the effects of this. What do I mean by that? Epidemiology suggests risks for mental disease, risks for non-communicable chronic disorders in many populations, risks of even intergenerational stunting, because I just mentioned, if you have fetal growth retardation because of maternal mental health issues, not just nutritional deprivation, that can have consequences in terms of your growth trajectories, in terms of your learning ability, in terms of your eventual human capital, that go way beyond what you would anticipate from a short-term exposure. So one should never underestimate the long-term effects of toxic stress. And having said that, toxic stress is not only restricted to conflict and not only restricted to displaced people, either internally or externally, refugees. We see this toxic stress here in North America in our deprived communities, in marginalized populations where children are exposed to nothing but drug wars and are fearful of even stepping out in the ghettos of many big cities. These toxic exposures are potentially much more consequential in terms of the health and wealth of nations than just mere things that you can recognize in terms of nutritional risks and other health impacts from short-term issues like COVID-19. Thank you.
Thank you very much, Zulfi. That was excellent. And what particularly resonated with me was the sort of unseen impacts, which you also highlighted in your presentation, and thinking about ways in which we can capture these early on in order to prevent more severe disorders developing down the line. I'll move on to Bukola. Questions for Professor Salami about her presentation. I see there's plenty. Bukola, I'll hand it over to you to field these questions.
There is a question about Ethiopia and the situation in Tigray, about the genocide happening there, and I do also second that there is a lot of atrocities happening in the region, and the situation in the region is quite sad. We just collected our data actually this year, I think between January and March. We collected our data at the same time when the situations there were unfolding. But the challenge that we had challenge, just like you said, collecting data in Tigray region specifically. There is a lot of bottlenecks and red tapes to be able to collect data in the region, and complexities and this difficulties. So we didn't actually end up collecting data in northern Ethiopia. Our data collection was conducted around our partner. We're from Jimma University in Ethiopia. So our data collection was collected around Jimma University, which is more of in the southern to eastern part of Ethiopia region. But yes, there is a need for more data in that region. And I think Dr. Cantor, Dr. David, has a question about there's a striking gaps between health on IDPs as compared to health of health research on other migrants. And yes, I think we did our scoping review of the literature that looked at health of migrants and also refugees internationally shows 188 studies, while the IDP study showed 25 studies on African migrant children. And when you look at, a lot of the research that has been done on IDPs tend to focus on, four main priorities, while the priorities of research that has been done on immigrant children and refugees children, especially in the global north, tends to be much broader, to focus on issues related to chronic health problems and broader issues related to neuro development. So I think in terms of some of the gaps in the research on IDPs, I know when we did our research, one thing that I didn't mention is a lot of the research also tends to be on those displaced due to conflicts. And we need to have more research in terms of climate change and displacement due to climate change, and the complexities about climate change displacement may be different. And we also need to have more research related to intervention studies, and also more research that sheds light on chronic health conditions that IDP may face. Dr. Bhutta talked about the role and impact of I forgot what you call this, the developmental origins of diseases in terms of, and we need to look at, in what ways is chronic health conditions shaped by issues related to trauma and issues related to chronic stress. I am just going down the list. Dr. Salami, did you identify as in your studies the lack of financial resources among migrant female, hindered their ability, accessibility to feminine pads? So the research that I conducted, this one scoping review was just on African migrant children. But we did, along with my doctoral student, look at a research project where we looked at reproductive and sexual health of internally displaced women in northern Nigeria. And in that study, actually, women were not talking as much about their health. Their central focus was actually on income as a determinant of health, because it's not just about feminine products. It's also about being able to just access basic health services. There was issues related to infectious diseases and being able to infectious reproductive diseases, and being able to just access basic services to be able to deal with some of these issues. So I would say that income is a vital social determinant of health. And in the past, we've applied for grants in the past to address the health needs of IDPs in Nigeria, reproductive health needs. And I remember we went to IDPs to collect data to see, what are their priorities and what would they like us to address. And, we said our focus was on reproductive health care. And they were clear to us, that do not address our health condition without addressing our main issue, which is income as a determinant of health. And in Nigeria, a lot of IDPs, that we interviewed, many of them, the families, they live on less than usually $1,000 in a day, and $1,000 in a day, 1,000 naira in a day, and 1,000 naira in a day. A lot of them, they were farming, So they were hired to farm on other people's land. 1,000 naira in a day would be around $3 or $2 to $3 in a day. And that's what these families live by. And that is not close to being sufficient. So a lot of IDPs are also predisposed to using to sex for money, to be able to actually meet their basic needs. So there's lots of complexities in terms of that. I will try not to talk too much about that so that there's time. Any questions? What can therefore be done to address these gaps in your knowledge, regionally and specific? Is there any way we can engage local populations and IDP to work? And I do believe that this is really the issue, and I won't say it's really to impress upon them to understand their health-related issues, because you cannot impress on someone to address health-related issues without giving them the tools to be able to actually address their health issues. So I do not believe that it's like IDPs do not want to address their health issues. No. It's more that they do not have the resources and the social conditions that are needed to be able to address their health issues, because I don't believe that someone, when you look at their several priorities, people will first seek security, and people will first seek to be able to just live before they actually seek to be able to improve their health status. So I think it's, one of the challenges that we have is also the governance system and the policy, the broader policy systems influencing IDPs, and addressing the health conditions of IDPs cannot just be limited to focusing on their health, but we must understand the policy jurisdiction, both national policy and international policy frameworks, and how it may or may not shape healthcare of internally displaced people, and also the broader social determinant of health. And I believe, yes, we can build capacities of IDPs. And when we are doing interventions, oftentimes, I think I come from a very post-colonial perspective or anti-colonial perspective, and look at in what ways can we actually provide the conditions for IDPs to be able to actually improve their health, while at the same time supporting them with a lot of the resources that they need to improve their health. Just tell me when to stop. If not, I'll keep going down until I'm done. Would mobile phone perhaps be a way to start to fill in the gaps? Yes, mobile phones have been used in the past to fill in the gaps in IDPs. And someone said Nigeria has the highest IDP in Africa, arising mainly from terrorism. Yes, that is true. And also farm conflict, that is true. Mental health access is a challenge for a lot of IDPs. From the people that we interviewed for another study that I didn't mention here in Nigeria. But oftentimes, it's like, yes, mental health is a challenge, but I have bigger challenges to deal with. And oftentimes, but of course, mental health does complicate the ability to be able to deal with a bigger challenge. One thing when we looked at IDPs in Nigeria, and we interviewed them about reproductive and sexual health, we realized the vital impact of mental health, because what was happening is we were going to homes and we will see a lot of the IDPs, they have between 10 and 12 children, right? So they will keep having children. And then we wondered, why do you keep having so many children? And a lot of them, it's because they lost their children in the process of migration. So they keep having children to replace that child that they lost in the past because of in the process of migration. So it's actually, the reproductive health was actually affected by the trauma they experienced in the past. And this tendency for them to say, I'm going to have children because I'm trying to replace Isaac that I lost 10 years ago or 5 years ago. But then they have, one child, and no, this is still not Isaac. I want to have another child to replace Isaac. So that was a very interesting finding by one of my doctoral students. I think I'm probably out of time, but tell me.
Thank you so much, Bukola. Yes, I'll stop you there so we can get to Ola and maybe do a second round if we have time. But thank you so much for fielding so many questions so well. I really appreciate it. Ola, over to you. I think there are a few questions posed regarding your presentation in the Syrian context.
Well, thank you very much, Diana. So the first one I'll take is around humanitarian agencies and access to displaced communities. And actually, this is a very, very important question around humanitarian access across Syria generally. As many of you will know, in 2014, because of the challenges of humanitarian aid going into government areas and then onwards into other areas which at that time were not under government control, meant that there needed to be a UN Security Council resolution where there was cross-border aid. And over the last couple of years, this has been an extremely fraught issue. So this is something that was being renewed annually. There were 4 border crossings, 2 for the northwest, 1 for the south, and 1 for the northeast. What happened in January of last year is the border crossing that supported humanitarian aid to northeast Syria, where you remember I said that there was a few 100,000 people who were internally displaced of the 3 million in that area, who had very high humanitarian needs in all possible ways, from health, nutrition, and then onwards. They have faced tremendous difficulties accessing aid throughout the COVID-19 pandemic from areas under government control. Just one second. And then for areas in the northwest,
Take your time, no worries.
So sorry, that's never happened before. So in areas of the northwest, in July of this year, we're very concerned because the one remaining border crossing for that area may well close in July of this year. And if you remember, there is about 4.2 million people in that area, 2/3 of whom are internally displaced and many of whom are reliant on humanitarian aid. If we think more specifically about getting into those communities where there is internal displacement, remember, often in the humanitarian sector, we focus on those who are in camps, but it's really important to remember that many are living with host communities, whether in rented accommodation, with extended families, and then onwards. And so in terms of access, of course, there may be logistical challenges, but in terms of the camps, depending on the relationships, whether it's with the local humanitarian organisation and provider or the international humanitarian organisation and provider, access into these displaced communities is possible. And actually there is some discussion and more work being done to ensure that the voices of those who themselves are internally displaced are heard. There's some very good examples from Northwest Syria and the COVID-19 pandemic. And then there's a question here around IDPs facing discrimination and accessing healthcare inside Syria. And it really would be interesting to hear what other speakers have experience around this, whether in Sub-Saharan Africa or further east. Syria before the conflict had a very rich tapestry with different religions, different ethnicities, different sects living in relative harmony for many years within those borders. The demographic changes and the geopolitical changes and the massive forced displacement and the massive violations to humanitarian law has destroyed the fabric of our society. Even the most horrific crime you can think of has occurred in Syria. And again, I'm going to bring up the issue around detainees because their suffering continues every day that they're imprisoned, many without charge. For those who've been forcibly displaced, I'm going to tell you a story. So for my family who are in rural Homs, they finally made the decision after multiple displacements of leaving after a massacre, coming back, leaving after government forces came into the area, but thinking about going back and perhaps leaving again. The option for the last time for some of my family members was to go to an area called Afrin. Now, Afrin was an area that had previously had a very large Kurdish population, but actually when they moved into that area, some of the Kurdish population were forcibly displaced. So there are lots of these demographic, ethnic tensions, and I'm going to call it demographic engineering that are happening across the country, particularly in the city I come from, which is Homs. What does this mean for health and healthcare access? Well, they may be seen as other. There is, of course, competition. What we haven't discussed as much as we should is if there's an influx of tens of thousands or hundreds of thousands of people coming in to use your local infrastructure, which is already destroyed and barely functioning, whether it be WASH, healthcare, education, and then onwards, you're seeing these newly forcibly displaced IDPs coming into that area through no fault of their own, competing with you. They may also be competing with you around jobs, for example. And beyond discrimination, something that was really interesting in the discussions around COVID-19 in Northwest Syria is we didn't see, we saw an early signal in the cities in Northwest Syria in terms of COVID-19, but actually we weren't seeing a rise in the camps until a bit later. And the reason for that is, of course, it wasn't that there's no COVID-19 in the camps. The camps are a fantastic place for SARS-CoV-2 to spread and propagate. It's because they didn't trust the local healthcare provider. So they didn't go to them and present with their symptoms. But also beyond that, they're far more limited in their ability to move across the area for a whole number of reasons, particularly when there is ongoing violence and attacks. Diana, I can take another question or I can stop there.
You have about a minute to take the next question. Please do.
So I'm just scrolling down to the very bottom. Excellent. I might stop there and then perhaps there's an opportunity for Zulfi or Bukola to add anything on either of those questions or any of the new questions that I can see are coming up.
Any other comments from the others before we close?
Well, there is one question in there. So I think I've provided the reference and context for some of the toxic stress related epigenetic issues, so I want to discuss those. But there is a very important question or comment related to what happens in long-term conflicts and to what extent is the responsibility with the state versus humanitarian agencies or any other groups, including, as you've also heard from some IDP communities themselves. So first of all, let me say that IDP communities, in my experience, at least in the geographies that I work, are almost never in a position of power. They are so vulnerable. Take the example of Ethiopian refugees in Somali refugees in Kenya. They're living in large slums, Kibera and other places, but they really are not a solid group that is either politically empowered or in a position where they can scream for their rights. And barring a few instances in the Afghan Pakistan sector refugees, at a very early stage when refugees were there, I find that IDPs are totally disempowered. They are vulnerable. There was a question earlier on from David as to what are the peculiarities of their social isolation. I mean, they are socially isolated because more often than not, they are uprooted from their roots. They come and live interspersed with local communities where sometimes they have networks and oftentimes they don't have enough networks. So it's an extremely vulnerable population, both in terms of how it affects their day-to-day living. They don't have housing security, they don't have security of other means, and they have no employment. And they frequently will therefore have to take on the most menial of tasks, if at all, and be further exposed to the way these mafias, the local mafias work. So it's toxic stress multiplied several folds because they have very little social safety nets, and they have virtually no exposure or no organized services as you would have in refugee camps. So internally displaced populations in camps are very different from internally displaced populations interspersed and mixed within communities. Sometimes the communities themselves may react negatively to them, and that's also been raised in the chat at one spot. I mean, what happens to their own limited resources if other people come and begin to partake of those resources? So why am I raising this now? Because when you have this kind of a situation going over decades, one or two things happen. Either people assimilate and become part of the community, and therefore they are indistinguishable other than ethnic markings from the local population, and sometimes they just become citizens, as has happened in many cases of Afghan refugees living in border areas of Pakistan since 1979. They are citizens now. They have identity cards, they have married locally, they have investments, businesses. So they are Pakistanis. But yet they have strong family connections. They go back and forth, and they represent a diaspora which is very mobile. In other instances, when they don't assimilate or have not succeeded in making that transition, they remain a vulnerable population, and they become the so-called, I hate the term when people ever use it, which is, the underclass. But they do become the soft belly of discrimination, and they become easily the so-called deletes or untouchables in any given society who are given the most menial of tasks. That is what we need to fight for. So over time, the state's responsibility for looking after people who are living within its borders and by international law have that protection becomes much more absolute. So I think the question that was posed is, to what extent in chronic conflict do we get to the responsibility of the state? I think there is a gradient, and over time that gradient increases with the state assuming a lot more responsibility for people who have been living under its protections for decades. Thank you.
Well said. Thank you so much, Zulfi. Thank you, Ola, for answering those questions about access, and to Zulfi for really addressing the elephant in the room, which is the role of the state in addressing IDP health. Thank you to our audience members for the very thoughtful questions. I'm sorry we won't get to discuss all of them, but we hope that this is the first of many conversations regarding IDP health, which will bring nuance to research and programming for these populations. Many thanks again to our speakers. I would encourage you to read some of their work in your own time and to be in touch with further questions. Once again, this webinar is part of a wider series run by the Health and Internal Displacement Network, and we hope to see you at our next webinar, which will be on Tuesday, June 15th at 3:30 p.m. UK time, titled Internal Displacement, Infectious Disease and Health Responses. We will now close the session. Thank you very much again. Thanks to our speakers, and please take care.